Hello, Assalamu alaikum. How are you, everyone? Today we are going to dive into geriatric medicine. We previously discussed Parkinson disease once, and in case of geriatric population, there is also another common issue that is called dementia. So let's try to unpack dementia in a palatable way. What actually dementia is? It is a neurodegenerative syndrome with progressive decline in several cognitive domains. What are the main cognitive domains? There are different cognitive domains like memory, learning, executive function, decision making, etc. The initial presentation is memory loss over years or months. But if memory loss occurs over days or weeks, we should not think of dementia. We should think of other causes like substance use of benzodiazepine or any history of epilepsy. 20% of people over 80 years of age are known to have dementia, but among them, 50% remain undiagnosed. So it is very common in geriatric population. So now let's dive into what are the subtypes of dementia. The number one is Alzheimer's disease. It is the leading cause. Second is vascular dementia. It is 25%. It is due to accumulation of small infarcts over time. We know the TIA and lacunar infarcts are very common in geriatric population. So accumulation of these cerebrovascular events lead to vascular dementia. There are several risk factors for these like hypertension, past strokes, and focal CNS signs. Then comes Lewy body dementia. It is associated with Parkinsonism. It is associated with Parkinsonism. Histologically, you will find Lewy bodies. What are these? These are eosinophilic intracytoplasmic inclusion bodies, most commonly found in brainstem and neocortex. Although the anatomical position of Parkinson's disease is in the substantia nigra, Lewy body are commonly found in brainstem and neocortex. That means that substantia nigra is not the sole anatomical position of Parkinson's disease. Other areas of brain may also lead to Parkinson's disease. There is a important saying here that they avoid using antipsychotics in Lewy body dementia. You cannot use antipsychotic in Lewy body dementia. That will lead to exacerbation of tremor and bradykinesia and rigidity. That are the hallmark symptoms of Parkinson's disease. And in case of vascular dementia, never use anticholinesterase inhibitor or memantine for these patients. We know anticholinesterase inhibitors, ribastigmine, commonly marketed as Exelon in USA, is very popular for dementia treatment. But if the patient has vascular dementia, it is advised or recommended to avoid. Also, memantidine, found in the trade name of Dementia in Bangladesh. The last one is frontotemporal dementia. What happens here? Frontal and temporal lobe atrophy with loss of 27% of spindle mechanism. What happens in frontotemporal dementia? Executive impairment occurs, behavioral personality change occurs. There may be disinhibition, hyperorality, stereotype behavior, and emotional unconcern. The person becomes emotionally unconcerned. That is kind of a stupor or catatonized behavior. Episodic memory and spatial orientation are preserved until late steps. So memory impairment is not a issue in frontotemporal dementia. Also spatial orientation. That means that they are well balanced. Pick's disease refers to the few frontotemporal dementia patients who have Pick's inclusion bodies on histology. Uh, what is Pick's bodies? These are spherical clusters of tau-laden macrophages. So if we do biopsy and histopathology of frontal and temporal lobe, we may find Pick's bodies. What are the Pick's bodies? They are tau-laden macrophages. So these are the subtypes of dementia. And so please now come how we are going to diagnose dementia. Diagnosis of dementia. From history, first from history, from the patient himself or any collateral narrative from the accompanying person. It isn't about timeline, decline, domains affected, non-cognitive symptom such as agitation, apathy, aggression indicate late disease. This should be marked that non-cognitive symptoms, not any alteration of the cognitive domains we already know. These are non-cognitive symptoms like agitation, apathy, aggression. That means that dementia has progressed and has reached advanced stage. Then we will do, after taking history, then we will do a cognitive testing by using a validated scoring system. There are two types of scoring system. One is AMTS and MOCA. You will find that in the internet, and then you can try that. Plus short test, we can do some short test of executive function and language. So detailed cognitive test includes AMTS and MOCA scoring, and short tests are done on outpatient basis that tests executive function and language. And we should also carry out a full mental state examination to identify whether there is any depression, any anxiety, or any hallucination. Then we will examine may identify physical cause or risk features like vascular dementia or Parkinson's disease. Then we will do medication review because some medications are associated with dementia. It is important to exclude that include cognitive impairment. Most importantly, benzodiazepine like midazolam and opioids like fentanyl and antipsychotics. So next, let's come to the investigation. What investigation we should do in a suspected case of dementia to firmly reach the diagnosis? First, we should look for reversible organic causes, like is there any hypothyroidism, any decrease in vitamin B12 level, any decrease in thiamine level, usually occurs in alcoholics and may lead to warnings and capability, and also hypocalcemia. So these are the baseline investigations we should do in case of a dementia. We will check for TSH level, we will check for vitamin B12 level, we should check for thiamine level and serum calcium. Then we will do some other baseline investigations like urinary CBC, urinary electrolytes, liver function test, and RBS. Because they indicate to reversible organic cause of dementia, commonly hypoglycemia, hypothyroidism, any sepsis, any hepatic encephalopathy, any uremic encephalopathy, etc. Then an MRI of brain. MRI is always preferred to image brain over CT scan. It exclude other irreversible causes like subdural hemorrhage and normal pressure hydrocephalus. So these are reversible causes, the structural reversible causes that are caught on MRI, as well as underlying vascular damage or functional pathology. Functional imaging, there are some functional imaging. Everybody thinks that functional means psychotic or psychiatric, but it doesn't actually true. Functional means any imaging modality that does not only delineate anatomy or structure, but also gives information regarding physiology of the organ. So functional imaging, FDG, fluorodeoxyglucose PET CT scan, may help delineate what are the subtype. We can delineate the subtype of dementia with this sort of functional imaging, and where diagnosis is not clear, we can also diagnose. Consider electroencephalogram in suspected delirium, frontotemporal dementia, Creutzfeldt-Jakob disease, Seizure, and Seizure disorders. So, electroencephalogram is done in suspected case of delirium, frontotemporal dementia, Creutzfeldt-Jakob disease, and seizure disorders. There is a term came here that is delirium. So, what is the difference between delirium and dementia? There are certain differences between delirium and dementia. So it is very important to isolate whether the case is of delirium or whether the cases of dementia. To distinguish these two conditions, the presence of inattention, distractibility, and disorganized thinking will all point towards delirium. I repeat, uh, any presence of inattention, distractibility, and disorganized thinking will point to delirium, not dementia. If clinically indicated, then we should check for autoantibodies against syphilis, HIV, and Creutzfeldt-Jakob disease. What is Creutzfeldt-Jakob disease? Creutzfeldt is a prion disease. There is no treatment for it, so it is irreversible. So we have covered what investigation should be done here. Then let's move to management of dementia. After suspected or diagnosed dementia, integrated memory services for further assessment and management. So, first step in managing dementia is to refer to the memory centers. These are science fiction in Bangladesh, but they actually prevail in advanced countries like European nations or America. So we can use medications. Before that, we should avoid drugs that impair cognition, like neuroleptics, sedatives, and tricyclic antidepressants. So, in case of a dementia, we should avoid these drugs that impair cognition, like neuroleptics, it is antipsychotics, sedatives, and tricyclic antidepressants. Then we can add some non-pharmacological interventions. Non-cognitive symptoms may respond to measures such as multisensory stimulation, massage. Multisensory stimulation, we can explain it by using aromatherapy that stimulates the olfactory centers. We can use music therapy that stimulates the temporal lobe auditory centers. We can do massage, uh, uh, and muscle and assisted therapy, physiotherapy, that is physiotherapy. So these are some non-cognitive symptoms may improve through non-pharmacological interventions. If we summarize, that those will be like speech therapy, like music therapy, aromatherapy, and physiotherapy. Then there we should consider other things too, because depression is almost always associated with dementia. So we can try an selective serotonin reuptake inhibitor like citalopram, 10 to 20 milligram per day. But on maintenance can be increased to 15 to 45 milligram if EGFR is greater than 40. Cognitive behavioral therapy, there is a form of functional psychotherapy. It will help with social withdrawal and catastrophic thinking. Capacity. Can the patient make decisions regarding medical or fundamental affairs? Wherever possible, allow them and suggest making an advanced lifetime or appointing a lasting power of attorney in early stage of the disease. It is socially and functionally effective. If the person cannot decide themselves about the treatment or economic affairs, then we should allow them to continue. And if it is not the case, we should arrange an early power of attorney to others. So, what are the other common causes of dementia beside the subtypes? It can be chronic alcohol or drug abuse, repeated head trauma, pellagra, that is vitamin deficiency, Whipple's disease, is GIT disease, Huntington's disease, Creutzfeldt-Jakob disease, Parkinson's disease, HIV, Cryptococcus neoformans induced pneumonia in HIV, and familial Alzheimer's disease and CADASIL. These are the other causes. So, what are the other causes of dementia? Alcohol or any substance abuse, repeated head trauma, pellagra, Whipple's disease, Huntington's disease, Creutzfeldt-Jakob disease, HIV, and Cryptococcus neoformans induced Cryptococcus neoformans induced Alzheimer's and CADASIL. So now let's start with Alzheimer's dementia. This is the leading cause of dementia in the this is the leading cause of dementia. It is a condition overlapping between neurology and neuropsychiatry. It is dealt with by both the specialties. Suspect Alzheimer's dementia in adults and dogs with progressive, persistent, and global cognitive impairment, uh, loss of visuospatial skill, memory and verbal abilities, and executive functions like planning, all are affected, unlike other dementias which may fit certain cognitive domains. So, in Alzheimer's dementia, there are the cognitive modalities that are affected are persistent global impairment of visuospatial skill, memory, verbal abilities, and executive functions like planning. There is also anosognosia. Anosognosia, lack of insight into problems and problems endangered by the disease. For example, missed appointments and misunderstood conversation and plots of farms or misunderstanding mishandling money. That is anosognosia. This anosognosia means that there will be lack of insight into problem and the problem endangered by the disease, like missing an appointment with the doctor, misunderstanding any conversation. If a person is not against you, still you feel that the person is having a conversation that is trying to bully you or down you. And there may be also a feature of mishandling money. Later, there may be inability, mood disturbance like depression or euphoria. There may be behavioral changes like aggression, wandering, disinhibition, and frank psychosis also, usually visual or auditory. And there may be agnosia, may, may not recognize self in the mirror. It is an interesting symptom. Someone standing in front of the mirror, but they don't recognize themselves. This is called agnosia. Uh, Cognitive impairment is progressive in Alzheimer's disease, but non-cognitive symptoms may come and go over months. Eventually, many patients become sedentary, taking little interest in anything. So this is important because if a person is so severely impaired with their cognitive demands that they suffer nihilism and become so sedentary, it increases the risk of cerebrovascular incident. So what are the causes of Alzheimer's dementia? Both environmental and genetic factors interplay here. Not only genetic, but also environmental factors. Accumulation of beta amyloid peptide. We should not go further deep into details. In histopathology, we will find accumulation of beta amyloid peptide. And there will be loss of acetylcholine. So that's why neuronal loss is selective. From which areas of the brain? The hippocampus, amygdala, temporal lobe, neocortex, and substantia nigra. These are the vulnerable areas where neuronal loss occurs in Alzheimer's dementia. So, what are the risk factors? We said that both environmental and genetic factors play a role. So, first degree relatives with Alzheimer's dementia, Down syndrome. People with Down syndrome will almost invariably, in 100% cases, will develop Alzheimer's dementia at some point of their life. Vascular risk factors like hypertension, diabetes, dyslipidemia, and these are the vascular risk factors and sedentary lifestyle, decreased physical activity. Okay, and there may be depression and any other mood disorders. History of smoking also play a role. So this is Alzheimer's dementia, and how we are going to manage Alzheimer's dementia. There is overlap between Lewy body dementia, Alzheimer's dementia, and Parkinson's disease, complicating treatment decisions. So treatment decision is very complex here in geriatric population because in geriatric population, dementia is not a sole subtype. It is usually mixed type. There are overlaps between Alzheimer's, overlaps between frontotemporal, Alzheimer's, Lewy body, and Parkinson's disease. So decision making is very important. Uh, Levodopa can precipitate delusions and antipsychotic worsens Parkinson's disease. Rivastigmine may help in all three cases. This is important. If we give levodopa in a psychiatric patient, it will aggravate hallucinations or delusions. But if you give antipsychotics in a Parkinson's disease patient, it will exacerbate the tremor. Acetylcholinesterase inhibitor like donepezil, rivastigmine, galantamine are all mildly effective in treating Alzheimer's dementia, and they are recommended by NICE UK. Okay. So dose, what should be the dose? Donepezil 5 milligram per orally, doubled after 1 month. Rivastigmine 1.5 milligram once daily initially, then increased up to titrated up to 3 to 6 milligram 12 hourly. And galantamine initially 4 milligram per 12 hour, and then 82 to 8 to 12 milligram per 12 hour per hourly. But commonly we use rivastigmine. We can use as swallowing tablet form or even use skin patches. The cholinergic effects of acetylcholinesterase may exacerbate peptic ulcer disease and heart block. This is very important. Rivastigmine is an anticholinergic drug, and it is a inhibitor of acetylcholinesterase. So it is a cholinergic drug. So cholinergic effects of acetylcholinesterase may exacerbate peptic ulcer disease and heart block. NMDA antagonist. These are another form of anti-dementia drug like memantine is reasonably effective in late stage of Alzheimer's and recommended in patients with severe distress on those with moderate disease in which acetylcholinesterase inhibitor are used but not effective in late stages. So, if a person's dementia is advanced and the person is ineffective or intolerant to rivastigmine, we should use NMDA antagonist. Dose is 5 milligram per 24 hour initially, 5 milligram to initially, then we can titrate it up to 5 to 10 milligram 12 hourly. Side effects, it may induce hallucination, confusion, hypotonia, and hypersexuality. And there are new treatment options like the monoclonal antibody. This is targeted therapy, amyloid beta monoclonal antibody like adusuzumab. And there is it is usually given after doing a functional imaging like FDG PET CT scan. When we should consider antipsychotics in a case of dementia, we should consider antipsychotics only in case of non-cognitive symptoms like frank psychosis or extreme agitations. But that should be done carefully, because if the person has the Parkinson, antipsychotics will further precipitate tremor. So please now come to another discussion, because managing dementia is actually a multidisciplinary action. We should include psychiatrists, neurologists, Parkinson's disease nurses, social workers, caregivers, family members. They all should be involved, because the medications we use are counterproductive, maybe counterproductive sometimes. Sometimes they are necessary, but exacerbating other symptoms, so it needs a multidisciplinary action. As the patient with dementia becomes sedentary, though there is increased risk of stroke and TIA. We also checked for supplementations of dietary and vitamins, but they haven't shown any promising effects, except for vitamin E. Except for vitamin E, so we can conclude hereby that vitamin supplementation does not work. So prevention in context of Alzheimer's dementia time course. Changes in CSF amyloid is seen in 24 5 years before onset of uh, equivocal symptoms and its deposition is detected by 15 years before by doing an USY. USY. So the pathology starts long before. So by doing CSF study of a USY CSF study, we can detect the pathological process long ago and intervene by global cognitive impairment therapy, CBT therapy to prevent or delay the onset of dementia. So I think that is more than enough for any general practitioner or any specialist from other specialty rather than psychiatry or neurology to understand dementia and help their near and dear ones. Thank you, everyone.